This is great to see everybody. I'm very thrilled that we have another meeting going on. It seems like it was almost yesterday that we were here last year. So I would like to introduce Will Durfee, who's done a phenomenal job as the chair of the program and tirelessly working for this. So, Will?
I join Art and welcome you all to our conference. Really appreciate you being here. Just one of the logistics note, on the card that's in your name badge, look on the back, there's a QR code, and if you scan that takes you to the online program. So if you get all the program changes that Art mentioned, you can just all find the most up-to-date information there. So we are doing something a little bit new in terms of the topic for this morning. And for the prior 12 years or so at this conference, we've been focusing on hardcore devices and have really been neglecting a topic that has come up to really be one of the most exciting and forefront areas of medical devices, which is information. It used to be that it was you and the doctor, and maybe the handwritten records, and maybe whatever the doctor had read in the latest medical journal. That era has essentially gone, or will be. Maybe it still exists somewhere out in the far reaches of society, but it is being replaced by information-driven medicine. And there's two things that have caused that to happen. One is the existence of very large databases. So, for example, United Health, one of the largest insurance companies in the world, which is located here in the Twin Cities, has terabytes of data about your own particular health and can tell you with incredible precision on average how much your health care is going to cost. So very large databases. And then the second part of it is coupled with sensor-driven data and ubiquitous sensing and ability to monitor at home, which is feeding into that database. So you've got these two large things going on that are going to revolutionize healthcare, but no one quite knows how. Everyone knows that it is rapidly moving, and everyone knows that it's going to be huge changes in the next 10 years, but how it's going to work out, no one knows. So this is why it's exceptionally fortunate that we have today's keynote speaker, Dr. Martin Kohn, who is going to help guide us through, best he can, through this incredibly exciting, wonderful, complex maze. So Dr. Marty Kohn is Chief Medical Scientist at Jointly Health, whose tagline is Big Data Analytics for Remote Patient Monitoring. And it's an early-stage, venture-backed company based in Orange County, California. Prior to joining Jointly Health, Dr. Kohn was the Chief Medical Scientist for Care Delivery Systems in IBM Research, where he led IBM support for the transformation of healthcare, including development of personalized care, outcomes-based models, and payment reform. While at IBM, he was also a key player in developing the use of the Watson supercomputer in healthcare. His research work includes healthcare population analytics and the role of expert systems in clinical decision processes. He's a board-certified emergency physician with over 30 years of hospital-based practice and management experience. He's a fellow of the American College of Emergency Physicians and the American College of Physician Executives, and is on the editorial board of the Journal of Emergency Medicine and has published multiple articles and book chapter on clinical, technical, and management topics. Has got an incredibly impressive education resume, having received a Bachelor of Science and Master of Science degrees from MIT, his MD from Harvard Medical School, training in biomedical systems engineering from Stanford, and an MS degree in health administration, policy, and finance from NYU. Dr. Kohn, welcome, and we look forward to hearing your comments.
Thank you. Thanks very much. Good morning, and thank you for the opportunity to join you here today. I actually did work with medical devices at one point in my career, although it was a long time ago. It was 1966. And I had a summer job in a laboratory that was studying artificial hearts. And so we designed some of the instrumentation used to manage the artificial hearts. That is the last time I did any work in developing instrumentation, although my work right now involves using instrumentation. And as Will mentioned, Jointly Health works in the area of predictive analytics, incorporating home monitoring data with longitudinal information about patients to identify patients with chronic diseases who are at risk of deterioration far enough in advance that you can intervene to prevent that deterioration. And it depends very, very critically on the data that we collect from home monitoring devices. So with that context, why is data or big data going to be important? If we look at the current state of healthcare, I'm sure you've all heard the statistics about how badly the US fares compared to other countries in various healthcare parameters, public health issues, and so on. The one statistic I read that kind of came home to me to demonstrate the problem is the United States was compared to the 12 other most developed countries in the world on this statistic of the likelihood of a 45-year-old person living till age 60. Okay, for a lot of people here, I think that's kind of close to home. Those are the power years, the development years, the influence years, the leadership years. Well, of those 12 countries, and this comparison was done for 1975 and 2005. In 1975, we were 12th out of 12 in the likelihood that a 45-year-old person would live till age 60. But we were spending about the same amount of money per capita as the other 11 countries. In 2005, we were still 12th out of 12, but spending 2 to 3 times as much as the other countries to own last place. Not a good place to be. Lots of room for change and a compelling argument for change. And if we look at some of the reasons why we are spending so much and getting so little, we can look at an article that was published in 2012 in the Journal of the American Medical Association by Don Berwick. Don had been the commissioner for the Center for Medicaid and Medicare Services, and also happened to be my classmate in medical school. And in his study, it estimated, depending on the assumptions you make, that between 21% and 47% of what we spend on healthcare in the United States is for things of no value. On average, 1/3 of what we spend is for things that are a waste of time and money. They don't help anybody, they just cost a lot of money. So there's a lot of room in there for improvement without hurting anything. The politics of that and the sociology of that makes that a little bit of a challenge, because as one of my health economics colleagues, who's a bit of a wag, said, one person's wasted expenditure is somebody else's desired income. Okay. All right. So somebody's going to have to lose in this process. That's sort of the given. But when Don and his colleague studied this, that they identified several areas that contributed to that waste. Okay. One is the failure of care processes. Okay. Not giving the patient a care process that was known to be helpful, therefore extending their illness, creating complications or whatever. And part of that is simply disseminating knowledge or making people comfortable using new knowledge. The Institute of Medicine some years ago estimated that the time gap from when something is proven to be of value before it becomes general use in the healthcare environment is 15 to 17 years. A variety of reasons for that. One of it is simply dissemination of information. A second factor that they identified was overtreatment, giving a treatment that has no potential to help a patient. A simple example, doing an MRI for low back pain. Okay. Lots of evidence out there that an MRI in low back pain is substantially useless, but it's still a common reason for getting MRIs. Okay. Administrative complexity. Once you decide what you want to do, how difficult it is it and expensive is it to implement it? Okay. For example, you decide you want to start some therapy in cancer, then you have to apply to the insurance company to get their approval that you can guarantee the patient's expenses will be reimbursed by the insurance company. And then failure of care coordination. If you have patients with, say, multiple chronic diseases, patients in the Medicare age group, on average, have 13 to 15 different providers. If they don't work together, if they act at opposing purposes, then there's a lot of expense, unnecessary complications, and waste. So what should the future be? If that's the current, what should the future be? Well, the same Don Berwick came up with the idea of the triple aim, that our goal should be improved population health, improving the patient experience, and controlling per capita cost. Some organizations add a fourth aim. So in industry, productivity is the fourth aim. In the military, readiness is the fourth aim, but they're all related. That should be our goal. That should be our concept of the future. So if we're going to achieve that goal, okay, if we're going to reduce the waste, if we're going to improve health, and we're going to control cost, okay, then we're simply going to have to make better decisions. Because the fundamental reason we have not done well is we have not made good decisions for all the possible reasons. So if we're going to make better decisions, that means we need to use the information available to us to make those decisions. And we have to create an incentive for people to do the right thing. So if I can make a decision that is best for you, okay, but making that decision is bad for me, say economically, there's not going to be much motivation to do it. Okay. So if I'm the radiologist and I make money off every MRI, okay, and I adopt an evidence-supported decision that says you don't need the MRI, then I'm helping you, but I'm hurting me. So one of these things is we have to change within our healthcare system the incentives. How are you paid? So what we need to switch to is an outcomes-based system. You don't get paid for each service you provide. You get paid for the quality of the income, of the outcome that you generate. That's going to require more decision-making. That's going to require coming up with methodologies that encourage people to do the right thing and rewarding them to do the right thing. And that's more data, more analytics, more decision-making we have to get in there. Another thing we have to do in the future is change the way we think about things and the way we train people in healthcare. Now, I studied engineering at MIT. And at MIT, my first engineering professor was Amar Bose of Bose Acoustics. First day in class, he said, okay, good engineers memorize a lot. Okay. Great engineers understand a lot, and they know where to find the answers. Totally different thought process than, it's the thought process that he elucidated for us. So it was emphasized throughout our educational career because most of the exams I took in engineering were open book and unlimited time. They all started at 6 p.m. after dinner. You stayed there as long as you wanted, and you brought into the room with you anything you wanted. The idea is if you didn't fundamentally understand what was going on, all that help and all that time were useless. Then I went across the river to Harvard for medical school. And what became apparent is the philosophy of education there was, how much rote can I cram into the student's head before they have a seizure? Okay. Critical thinking was not part of the curriculum. Now, back then, this is in the 60s, maybe that made some sense, because the challenge in the 60s was collecting the information, was getting information. The sources were fairly limited. Okay. All you would have about a patient was in the written record. Okay. If you wanted to study a subject, you went down to the library, and I see some gray hairs here that people may remember Index Medicus. You pull down the volume of Index Medicus, which was like a Manhattan phone book in thickness, okay, and you thought of all the possible categories that your question could fall under, and you went through each of these categories in each of the editions of Index Medicus and wrote down on a pad, because there were no PDAs or anything back then, the names of articles that you thought might be relevant, and then you hoped the librarian could get them for you. And you could spend 2 or 3 days and come up with 20 articles. Now you go online and you get 103,162 hits in 0.12 seconds. Okay. So the challenge back then was getting the information, so you weren't overwhelmed by it because there was so little of it and hard to get. Now you're overwhelmed by it. So now what we need is not the ability to collect data, but the critical thinking necessary to evaluate and use data. So I would argue we need a fundamental change in the way healthcare is taught, the way medical students learn right now, which is how do you use data? Because you're going to get all this data, and you just can't read it all. How are you going to process it, evaluate it, and use it? And then we need to learn how to play well together in the sandbox and work with the different caregivers and stakeholders in healthcare. And again, all of these things are going to fundamentally require making better decisions, using information that's available, sifting through all the information that's available. So in terms of how to use information in this specific area of clinical decision support, I've come up with the ideas for me that help me. I call them the 5 Ps. Okay. We want to make decisions that are personalized, because one of the reasons we waste so much and are so inefficient is we treat patients as if they fit monolithically into a category. You're a diabetic. I'm going to treat you like every other diabetic, despite the fact that we know that 20 to 30 to 40% of patients with a specific disease do not respond well to the standard therapy. But the way we usually find that is we try it and it doesn't work, and either they don't get better or maybe they get worse, and we stop it and we try something else. It's kind of this experiential sort of model, when ideally what we would like to do is say, aha, you are diabetic, but that's not the only thing about you. There are many other characteristics about you, and I should be able to use that information to increase the likelihood that the intervention I will choose for you will work for you as an individual. So we want to personalize, or another way of describing it is precision healthcare. We want to move to prevention. Okay, right now, 75 to 80% of the money that's spent in healthcare in the United States is spent on treating people with multiple chronic diseases. Okay, we have no choice right now. That is where all the money is going. But ultimately, we want to get to prevention. So our first strategy right now is what's sometimes called secondary or tertiary prevention. Patients with chronic diseases, you want to prevent them from deteriorating, slow down their deterioration, prevent them from having complications. But ideally, we want to move to primary prevention. We'd be much better off if patients didn't develop the chronic diseases rather than treat them after they got them. So that leads to the 3rd P, which is prediction. Identify such patients and their risks and what we can do to mitigate against those risks. And that requires the 4th P, which is patterns. This is where we're getting into big data. Okay. All experienced healthcare people use patterns after a fashion. Okay. And it might be a proxy for experience. So when I was in the emergency department, for example, if an elderly patient came in who was hypothermic, low body temperature, tachycardic, rapid heart rate, confused, and diaphoretic, sweating, that pattern meant sepsis. Okay. It didn't guarantee sepsis, but it was a pattern that represented sepsis. And sepsis is one of those diseases where even 20 or 30 minutes difference in initiating therapy can dramatically change the outcome. So when I saw that pattern, I treated the patient for sepsis. I didn't do any tests. I treated that patient for sepsis, and then I did the tests afterward, because that 20 or 30 minutes was so critical. Now, my internist colleagues, who like to be critical of the work we did in the emergency room, said, hey, 70% of the time you were wrong. That patient wasn't septic. My argument is 30% of the time I saved that patient's life by treating them right away. So, but patterns are all part of it. In big data, one of the premises of big data, which is, I'll talk about the detail of big data in a second, is that there are patterns in that data that humans can't see. I can see this obvious pattern of hypothermia, tachycardia, and so on. But there might be other information about that patient in data I could collect about the patient that would have told me 2 days earlier that that patient was going to be septic. That would have been very helpful. So patterns of information in big data that we can't perceive, but computers can detect, is part of big data and clinical decision support. And then the 5th P is persistence. This is not a trivial task, bringing this into healthcare. It's a new idea. It requires new kinds of thinking. And our political and social environment is a major challenge. It seems like our political environment right now is the main objective of each party is to make sure the other party doesn't do anything for which they can take credit. So consistent with that, and I'll show you a better slide for this in a moment, a state senator from Virginia submitted a year ago, January, a bill to the Virginia Assembly prohibiting the use of healthcare analytics for managing populations. So specifically, prohibited the state of Virginia, anybody in the state of Virginia, from performing any analytic or statistical processing with regard to any medical records for multiple patients for purposes of medical diagnosis or treatment. Okay. Now, fortunately, that got voted down in committee, never made it to the floor. But in committee, 2 people voted for it. That environment makes it a little difficult to make some progress. So we're dealing with this along with all the other technical issues. So what is big data? Okay. And I want to change things. My title said how big data is going to transform. Okay. That isn't actually my preferred title. Big data is going to be involved in the transformation, but for reasons I'll explain, it won't be the transforming agent, but it'll be an essential part of it. Big data is one of those things where if you ask 4 different people, you get 5 different definitions. Okay. So we stop talking about a definition of big data and just talk about its characteristics. And it's often referred to as the 4 V's. One is simply volume. How much data? I personally don't think that's the major challenge. We're very good at, responding to big data. When I first got my first desktop computer back in the early 80s, and Lotus 123 came on the 5.5-inch floppies, you were limited to 64 rows and 64 columns. Anything more than that was big data. Okay. Now you use Excel or whatever it is, and it's unlimited. So the volume itself is not the problem. The second V is velocity, how fast the data is coming at you. That's a bit of a challenge, okay, because sometimes it's coming at you so fast, and the time frame in which you have to use it to make a decision is so short, you have to develop techniques for dealing simply with the velocity of the data. And that area of big data analytics is sometimes called streaming data analytics, streaming analytics. And that typically happens in a place like a large intensive care unit where you have lots of people with multiple physiologic monitoring devices, and all this data comes flowing at you. So some of my colleagues, former colleagues at IBM, worked specifically in streaming analytics. And what their goal was is to identify patients in critical care units that would develop a complication far ahead of time when you can avoid the complication. And one of the first projects they did was at Toronto Sick Kids Hospital in the neonatal ICU, monitoring premature infants. And what they were able to do using predictive analytics and streaming analytics is identify those infants that would develop neonatal sepsis 24 hours before it became clinically manifest. That there were patterns in all that streaming analytic that said in 24 hours, this baby is going to be obviously sick. Okay. So early enough to change the outcomes dramatically. So the third V is variety. We have all different kinds of information. We need to learn to use it all. Okay, so we have streaming analytics. We have structured numerical analytics, like your laboratory reports. We have image data, like MRIs and echocardiograms. Okay? And we have natural language free text information, like journal articles, the narrative part of the electronic health record, your textbooks, the guidelines, all sorts of free text language. That is amongst the most difficult data to use, because until recently, we didn't have any tools that actually helped us understand the meaning of that written language. We had lots of tools that could identify patterns of words or combinations of words, but none that actually helped us understand the meaning of the language. And that's where Watson came in. And that's one of the things I was working on while I was at IBM. What Watson's specific talent is, it understands the meaning of English. Okay. It was designed the project was a 4-year project to demonstrate that a computer could actually understand English. So most of you probably were aware of Watson from when it defeated the reigning Jeopardy champions about 3 years ago. That was not IBM's objective. Okay. Its senior leadership knew that playing quiz games was not a long-term business model. Okay. The goal was to demonstrate that Watson could actually understand English, and Jeopardy was the arena in which it was able to show that. Because Jeopardy uses language, intentionally arcane language in its clues. And Watson was able to interpret and understand the clue. And then was able to understand language well enough to read 200 million pages of text in 3 seconds and pull from that reading the information it needed to create the appropriate response to the Jeopardy clue well enough to defeat the two champions. So that is how now it's being applied in healthcare. So one of the projects I was working on was with Memorial Sloan Kettering Cancer Institute in New York to help make suggestions on therapy for patients with lung cancer. And again, what Watson was designed to do is to make suggestions. Unlike it appeared in Jeopardy, where Watson actually gave the single answer, That's not how Watson works in healthcare. Watson in healthcare is decision support. So it has been taught to understand the critical attributes of a patient with cancer, go out and read hundreds of thousands of articles, and come back with ideas for the decision makers to use to make a better decision. So it's truly decision support, using the existing data. Okay, what we call knowledge-driven decision support, the assumption that the knowledge exists in print someplace. It's a matter of finding it and bringing it in relevant and context for the decision maker. That's fundamentally what Watson does. That component, that natural language, free text part of the healthcare information we have. Then the fourth V is variously called variability, value, or veracity. And it speaks to the fact that when you have lots and lots of data, a lot of that data is going to be flawed, it's going to be incorrect, it's going to be inconsistent. So you're in the ICU and your EKG monitor says the heart rate is 60. Your blood pressure monitor says it's 120. Okay. One part of the electronic health record says the patient's allergic to penicillin. Another part of the electronic record says the patient successfully got penicillin. Okay. New England Journal of Medicine says this is the way to treat this problem. British Lancet says this is the way to treat that problem. You have to deal with all that inconsistency, all that conflict. Okay. Not traditionally the way we have worked with things. So that's the fourth V of big data. And the amount of inconsistency we have is increasing. So this is a graph from IBM's Global Technology Outlook from 2012. IBM every year creates this GTO, Global Technology Outlook, for what technology is going to look like in the next 5 years. So what they concluded is in 2005, using all the different kinds of healthcare data that there are, including sensors and devices, that 80% of the data we use will be inconsistent starting next year. So we need analytic processes, analytic tools that help us deal with that conflict, okay, to understand the impact of that conflict and inconsistency and how reliable would the conclusions be if we use that inconsistent data. Okay. So when we talk about big data, okay, and how we use big data, it leads us to certain kinds of problems and certain kinds of opportunities. Okay, big data is big opportunity. Okay, but as mentioned, with all this inconsistency, it may not be very reliable. So one of the premises of big data is looking at it somewhat differently from the traditional experimental design. The traditional experimental design is you start off with a null hypothesis, okay, and then you set up your review, you set up your analysis, and you find out whether your null hypothesis was sustained or not. Okay. And the idea is you come up with a single null hypothesis, because if you pick too many hypotheses in your experimental design, you increase the likelihood that one of them will turn out to be positive just by chance. So the idea is you stick to one, or if you're going to use 2 or 3, then you use correction methods to try to make sure that reduce the likelihood of randomly coming up with something that has statistical significance. It's kind of the reverse with big data. Big data very often is analyzed from the non-hypothesis methodology. You look for those associations in big data. And the reason you don't start off with the null hypothesis is because those patterns in the big data are ones you can't anticipate or even ideate about. And if you start off with the null hypothesis that you have offered, okay, that means you're limiting the analysis to things you can think about, that you can understand, you can perceive. And there's more information in big data than we can think about. So you don't want to constrain yourself that way. Okay. So that leads to some of the limitations. And big data now is becoming enough of the common phrase, the common language, that it's being written about in the lay media, not just in the technical media anymore. So, for instance, the March issue of Atlantic Monthly was about big data. Okay. This article in the New York Times yesterday about big data, limitations of big data. Okay. And one of the limitations is it's very good at detecting correlations, okay, especially with this non-hypothesis approach. But the challenge then becomes, what is meaningful? What is the causal relationship? So I can analyze big data and get lots of associations. Okay. But what I need to do is close that gap in causality, because big data, straight big data analytics doesn't tell me about causality. I can see an association between some events and some information and the outcome of somebody with a myocardial infarction. but I have no direct way of proving that there is a causal relationship. It might just be random. So one of the challenges is when you see these associations, how are you going to go back and look at the associations that you've created, you've identified, and identify the ones that actually make a difference? Okay. One of the real challenges. So Nate Silver, who runs the 538 blog for the New York Times, he predicted correctly 34 or 35 of the Senate races in the last election and predicted precisely Obama's outcome in each of the states. He talks about this data, and one of the challenges in big data, especially with all the inconsistency that I mentioned, is when you model big data, you try to come up with these analytic tools, is you're not always sure whether you're modeling signal or noise. Okay. And when you model noise is when you come out with these associations that have no value. So what he proposes, and he suggests, it's a combination of the statistical analyses with the domain experts. So he talked about this in politics, he talked about this in meteorology. Okay. And so all these statistical models on weather systems work well to a point, but they work even better when they're interpreted and used by people who are experts. So it'll be the same thing in healthcare. Big data gives us lots of opportunity, but lots of challenges and lots of limitations. So the result then is that, again, these are all quotes from the article in the New York Times, that big data can work well as an adjunct to scientific inquiry, but is not the be-all and end-all. We need people to interpret and use it because we have that risk of too many complications. And the main complication we may have right now is the hype for big data. Okay. I think it's being overblown. Okay. So people talk about big data transforming healthcare. Okay. That makes me very, very uncomfortable. Okay. Big data can be an enabler to transform healthcare, but it is not the driver of healthcare. It is not going to change any of our problems. It gives us some opportunities, but those opportunities are only going to be acted on if we handle it well enough. And what are the sort of problems that lead to this conflict and why we have trouble with it? Okay. For most of you, what you've heard about Watson from all the publicity, and not all of it came from IBM marketing, some of it came from the other media, is it probably painted Watson as being omniscient and omnipotent. Okay. Watson does everything. You have a problem, ask Watson. Okay. And you get the answer. It isn't the case. Okay. Watson has a specific ability. It can read and understand English, okay? But it can't tell you if somebody's lying, okay? It can look around and see if there's other supporting information in other articles, but it can't look at one article and say, this is nonsense, okay? It can't overcome the publication bias that more likely that positive studies will be published rather than negative studies. It can't overcome that. And then you have research done by John Ioannidis from Stanford. And he said much of what medical researchers publish is misleading or just plain wrong. Okay. And he came up with an article that said, looking at studies that have been published, that very few of them can ever be reproduced. Most of them are flawed or wrong. So if your core information base is flawed or wrong, a tool like Watson is not going to solve your problem for you. And whether that's in the written information or in flawed collected digital information, we still have that problem. So I find myself in kind of a schizophrenic conflict out here. I'm trying to convince you that big data is important. Okay. Okay. We need it, okay, because it's the only way we're going to collect information, get enough ideas to make better decisions. On the other hand, it's not a panacea. It's not a silver bullet. It's a real challenge to use it effectively. Okay. So the medical community is starting to recognize this, okay, that using data is itself a requirement and a challenge. And so programs in information technology, health analytics are being developed in many schools around the country. Formal medicine finally recognized this after a fashion last year. In 2013, a brand new medical subspecialty was created called clinical informatics. Okay, so now there are 400 of us in the country or so that are board certified in clinical informatics. In and of itself doesn't mean very much, except that I think it represents a recognition of the fact that being able to use healthcare data with all its flaws and advantages is now part of the future. We're going to have to use it whether we like it or not. Okay? It's part of the future. It's going to change the way we think. It's going to change the way we make decisions. So in that context, something that flawed, that complicated, that difficult, it really can't be a transformative agent. Okay? People like you are the transformative agents that want to do things better and do things differently. So at best, clinical analytics, big data, is an enabler of that transformation. We know where we'd like to be 5, 10, 15 years from now. I love to predict things, what it's going to be like 10 years from now, because nobody will remember that it was wrong. Okay. So at best, when we have this vision of the future, we define a path on how we want to get there, whether it's a new medical device to solve a problem, and then we will see obstacles to getting there. And a lot of those obstacles are proving, for example, the value of what we want to do, or how to overcome access to information or use of information to make better decisions. Then the technology involved in big data and clinical informatics and decision support are enablers because they help us overcome those obstacles. They don't themselves drive the change. People have to drive the change, the desire for change. As I mentioned, I can prove all along that the MRI isn't useful. Okay? But if people aren't willing to use that data to make better decisions, the analytics are a waste of time. Okay? So at best, these tools will augment human perception, analysis, and decision making. But the fundamental desire to make those changes, to think that way, has to come from the people. And this applies to medical devices too. Okay? The future is going to be prove that what you have has value. And because our goal in the future is improve health outcomes and control costs. You know, back in the 60s and 70s, if something sounded better, somebody would pay for it. Okay. I have an MRI that has 2% better resolution. It costs twice as much as the existing one. Somebody would buy it. Okay. That's no longer the case. Okay. The future is going to be you have to show real value, that you've made a difference. And this is going to be part of what's called rapid learning in healthcare, where you do clinical trials, you try out your experiments, you feed it into the decision-making process, you act on the information you have, you get feedback on what happened, did it really improve the outcome, you feed that back into the system. And it's a cycle of incorporation of evidence and improving decision-making over time, called rapid learning in healthcare. Now, as remember from the statistics I gave you before, rapid learning in healthcare is very different from rapid learning in anything else. Rapid learning in healthcare is anything under 15 years. Okay. But this is all part of the cycle, and this is where this information fits in. And within the medical device industry, you're going to be part of this. Okay. And you're already seeing some challenges. Again, in the lay press, there was a recent article just this week in the New York Times about medical devices and the cost of medical devices and how expensive it's making healthcare. Now, one of the special things about the cost of healthcare in the United States, which is now about $3 trillion a year, is each component of healthcare argues that it represents just a small percentage of the total cost, so don't bother me. Okay, physicians say, we're only 16% of the cost of healthcare, don't bother me. You eliminate all physician fees and you're still left with 85%. The medical device industry says, we only spend 4 or 5% of it. You know, don't bother me. Making me be cheaper is not going to change anything, except to the person who has to buy the device. Because, back, say, in the 70s and 80s, if you had good health care coverage, okay, you paid almost nothing, right? You might pay $5 or $10 for a hospitalization. But now, even with really good health care insurance, a typical family can spend $5,000 or $6,000 out of pocket without any serious problems. And if you have serious problems, it can be $10,000, $20,000. That's your copay or your deductible. So people now are starting to pay attention to that. And if you're one of the people that has to buy one of these medical devices, even if you're only paying 20% of it, it's very substantial. So it's led to some of the comments that were in this New York Times article and a similar article in some other papers, that even small medical advances mean a big jump in bills. Okay? A lot of the so-called updates and improvements are dubious. Okay? These are what people are saying about the industry. They may be better in some abstract sense, but clinically inconsequential. That's going to be a key part of the conversation. Okay? Does this really make a difference in the clinical outcome? And diabetes experts claim that a lot of what encompasses innovation actually is just planned obsolescence. So you're going to have to overcome these obstacles, whether they're true or not, and I don't know enough about the industry to argue that, but if this is the perception out there, and the thrust is documenting that you make a difference, you're going to have to pay attention to this. So we're in the era of big data, whether we like it or not. Okay. It has great potential, it has great challenge. It's the area I work in, so it's how I make my living, so I have a bias towards it. Okay? But it's real, and it's one of the things, not the only thing, it's one of the things that has the potential to support us in our effort to transform healthcare, but only if we work with it and if we use our expertise to know how to apply it and help us make better decisions. So my concept of decision support is I don't want tools that tell me what to do. I want tools that help me use all this information that's out there to help me make a better decision. I think that's what big data is about, and I thank you for your time.
It's still unclear to me what the inputs are to this big data. As a clinician, what am I uploading into the computer? A computer can only do its magic once a human puts the information into the computer and says, compute it in some way. So are we uploading patients' genetic data? Are we uploading home telemetry data? Are we uploading clinical history data saying the patient's pain has persisted for 3 months and the pain is located at a certain anatomic site? What are the inputs to this big data that you see clinicians will be using in 2020, 2030, 2050?
Well, the simple answer is any and all. But one of the challenges is what is relevant. So we make diagnosis in healthcare. We've been trained to use certain kinds of information, certain parameters that we use in making diagnosis within the framework we've been taught to think about it. We very rarely study whether that information really is as predictive or explanatory as we think. That's just the way we were taught. So again, one of the premises of big data is the more data, the better, but part of the analysis is any of that data relevant? So the theme is, again, more data, the better. Give me everything you've got, and then I will develop the tools to analyze it and see if in fact it's relevant. So what may be relevant of all that information that's out there with all its conflict, what I call kind of a confused sea rather than an ocean of data, because so much of it is in conflict, then the tools will decide what information there is relevant for the decision that you choose to make at the time. And so that may give you some insight, but then you will give feedback to the system. You will say, gee, that's ridiculous. You're all wrong. Or, wow, that's really helpful insight. Thank you very much. So part of this rapid learning cycle is feedback from you as to how well the information was helpful to you. So eventually we'll want all that information, because when you make a decision about a patient, if you're trying to make a personalized, specific decision for that patient, you'll want the advantage of all the different kinds of information that's there. So you will live right now with what's available, but the ultimate goal is everything.
Hello, thank you for a wonderful talk, Pankaj Gupta, Lake Region Medical. To follow up on that question, as a medical device manufacturer, we interact with physicians to get feedback, what's the need out there and to develop the medical device. But it's an expensive process, and we have, limited physicians, we can tap into. So depending upon the data you are taking into this big data, do you see, in future medical device companies can tap into the data and see, what is the need out there and what's need to be developed and so forth, and how far we are away from that?
Well, I think it's going to have to be a two-way street. Okay? For instance, with the work that I've been doing, we would like to get all that data that the medical device manufacturers have about the devices, and make that part of the pool of information that we analyze, and share it back and forth. That, I talked about, the social and political environment, the challenges to sharing data, especially across state lines or across international lines, or with people like this state senator in Virginia. In my mind, it's desirable. In fact, it'll be necessary. But how we're going to work that out, because there are still organizations that take the knowledge as power literally and say, I've got this knowledge, I'm not going to diminish my power by sharing it with you. So yes, we need to be there, and how quickly that's going to happen, how easily that can be happening is a little bit up for grabs.
You alluded to this earlier. I'm curious what your thoughts are on how we change the culture with journals to be more accepting of confirmations of the null hypothesis, because it seems like anytime you don't have those positive results, it's perceived as a failure, but you could really be advancing the science of whatever technology you're working on by publishing that.
Yeah, and that requires a change in mindset. So, in my mind, the biggest challenges are not the technology per se. We have the ability to create new technology as it's needed, but dealing with the social and political obstacles, I think, is one of the most difficult areas. And there's, even within government, there's lots of desire for that kind of information. So I was working with a part of HHS called ASPR, the Assistant Secretary for Preparedness and Response. Their job is to prepare the United States for the next unknown biological or chemical threat. Okay? And so one of the things they were interested in was getting reports from the pharmaceutical industry about drugs that did not make it through approval. And why? Suppose there was a drug that got dropped in its development because it, say, had a 20% mortality rate. But if it would be effective in a threat, a biologic threat that had an 80% mortality rate, then it would be a good drug. But they don't have access to that information. So that mindset is, whether you're embarrassed about displaying your failures or whatever, that's a social obstacle we have to overcome to get that, because that's important information that right now we can't get, and no tool will compensate for that.
Next one's over here.
Hi. Can I just give you a key word and then get your thoughts on these?
Okay.
Telemedicine. And immediately you go to a patient at home with a computer, with the doctor, or you send a PA or somebody to the home who examines the patient. And then, of course, you can go beyond that in terms of your monitoring. But somehow this will fit into here. Yes.
Telemedicine already does fit in. It has some very well-defined successful roles, particularly, for example, in far rural areas. The provincial governments in Canada use that quite a bit, for example. So like in Ontario, since, like your healthcare coverage in Canada is very comprehensive. So, Ontario's a big province. It goes all the way up to Hudson's Bay, and there's some very small remote communities up there with no healthcare worker other than a PA. And what they would do if somebody needed to get a consultation from a doctor, besides paying for the health care, the province would pay to charter a plane to bring the patient and a relative into Toronto and put them up in a hotel while they got their evaluation. And now what they do is remote telemedicine. So they have the PA up there, they have telemedicine screening, and they can get the consultation with the physician remotely. So this is going to be, a more progressive part of healthcare of the future for specific applications.
Then the other thought, do surgery. Probably all operations should be video and recorded, because for the next person that comes along and has to look at this, but we don't do this at the present time. And the other key word I had was the medical legal. And then, of course, you went to Harvard, so everybody's well-trained. But it's a great way to tell who's well-trained and who's not well-trained. I'm not going to go on, but if you could comment on those.
It's the fact that I went to Harvard, I would have to say, does not give you any guarantee that I was well-trained. There is a certain kind of self-deprecating humor about this sort of thing. What do you call the person who graduated last in medical school? Doctor, right?
Can I give you, from Indiana, and this is Don Wilson, who's an ophthalmologist at Indiana and was 6'7" and played at Butler. They always ask you where you graduated in the class, and Don's answer, which I always use, is, I made the other half of the class possible.
No, I have to admit that my educational pedigree has given me some advantages, but I wouldn't objectively want to argue that they were valid.
Thank you for a great talk.
You know, there's great motivation by hardware manufacturers and software manufacturers to really go after this big data, not only for healthcare, but for many, many other industries. You know, let's say we get to a point where we have a Watson in our pocket. And you point out that there's an interpretation function that needs to be done. So let's say you're ER doc and it's 3:30 in the morning at a remote hospital outside Minnesota here. You need the information. Do you think there's going to be a new industry or a new function that helps do that interpretation in a very smart way that will help that ER doc?
Well, I think there are two steps there. One is the ability to collect and share the information. So when I was in practice, where I practiced last, there were 5 major hospitals within a few miles of my hospital, none of whom shared any information. And so why would, 3 in the morning, I'd get a patient in to the emergency department who was cared for at one of the other healthcare institutions. I'd have no information about them. And I'd find some abnormalities. If I had access to information about the patient, historical information about that patient, I could have interpreted those abnormalities in context. But somebody comes in with chest pain, has an abnormal electrocardiogram, I have to admit them because I was not able to collect the information that allowed me to judge that it was safe for them to go home. A lot of those admissions were probably avoidable if information could have been shared. So simply getting information to share information that's within the realm of how you can think about things is the first step. Then the second step is, getting help in interpreting massive amounts of information. But right now, the information that an individual practitioner gets isn't in the big data realm. At some point it will be. But yeah, those are all steps. So first I want the information, and then if I need it, I want help interpreting it.
Yes. I liked the last slide you were talking about, trying to decrease the cost by, decreasing little steps, right? But my aunt owns a stain, they stain cells to see if they're cancerous, and she tried to put it at a low price. However, they wouldn't sell, so she decided, I'm going to put it a step above all the other competitors, and then her sales boomed. So how do you change this type of, ideology so that we can actually start decreasing the costs of these things?
Well, that's another one of the important sociologic challenges, changing this, this whole reward system. So one of the evolving healthcare policy or healthcare environments that is going to address that are the accountable care organizations, or the accountable care-like organizations, where an integrated delivery group, a network, agrees to take care of a group of patients for a fixed amount of money. And their obligation is to control cost and improve the outcome, unlike the HMO models of the 70s, where the goal was just reduce utilization irrespective of the impact on outcome, just save money. Here now the goal and what you're obligated to do, and you have to prove you have done, is control cost and improve outcome. So places like Geisinger have done that fairly successfully, where they come up with a reward structure for their participants in healthcare that rewards them for good outcomes, not just for services rendered. So when you're in the environment where you prove to me that what you're going to do adds to my value proposition, allows me to care for these patients better and limit my overall cost, indirectly, that's going to be the influence on that sort of thing. I can do it cheaper. Now, within looking at cells, for cancer, that's an area where data analytics, image data analytics, are probably going to have an impact, because pathologists, people that review these things, or when did pathology rotations in medical school, you're trained to look at certain things within that cell image that tell you whether it's cancerous or not. And it has a very high false positive and false negative rate. That's just part of it. But image analytics that ignore those specific things, because it looks at I'm going to look at thousands of images of cancer cells. I know they're cancer cells because the patient grossly has cancer. And I'm going to look at thousands of images of normal cells. And I'm going to decide for myself, this machine is going to decide for itself what distinguishes cancer from normal, and probably do a better job. The analogy where I worked indirectly was back in the 60s, computer interpretation of electrocardiograms. A guy named Cesar Caceres at George Washington University was one of the first people to use a computer to interpret electrocardiograms. He was a cardiologist. He programmed a computer to interpret an EKG the same way a cardiologist did. PR intervals, QRS durations, and so on. And it turned out, lo and behold, to be about as good as an average cardiologist, but it consistently made the same errors that the average cardiologist made. Okay? Then some guys who did some present work at Stanford say, this is silly. We're going to look at this as an electrical signal and let the system decide how to categorize it. To be much more effective. So, every one of these things is subject to improvement and change, but the motivation has to be there, and something like the accountable care-like organizations are going to provide that.
Thank you for taking the time to be here. My name is Kyle Johnson. I'm interested in consumer-level wearable devices and the advent of being able to track biometrics on anyone continuously. How do you see this affecting the predictive and preventive qualities of big data on a population scale?
Well, it can certainly provide advantages, but my first response to that kind of question is, so what? I was giving a talk out in Silicon Valley a couple of years ago and met Vinod Khosla. I don't know, he was the founder of Sun Microsystems. He's a multi-billionaire, runs a very large healthcare-oriented venture capital firm. Amongst other things that he and I disagree on, he's one of these people who thinks that all these analytics ought to be prescriptive and determinative. He, as he phrased it, in the future, I don't want to be managed by doctors, I want to be managed by algorithms. So he has a unique mindset on this. He wants everything to be done by machine. He had this device put on the back of his iPhone that could transmit his electrocardiogram to his doctor. He said, I can send this to my doctor 100 times a day. I said, so what? How do you know that has any value? So in the sense of an experiment, if you, like right now these devices are getting so small that there's one company that's coming, it's basically a tattoo. You don't even know you have it on, and it still sends 5 parameters. If as an experiment you were to monitor people to learn whether that has any value, I'd be in favor of it. But to set up an industry that looks on collecting all that data as if you know it's going to have value, I think is the wrong way. That's sort of reminiscent of the technology approach in the 60s and 70s, where you develop the technology first with the full hope and expectation that in that freewheeling environment somebody would buy it. You need to prove it has value. So we work in that area, and we work with some very small devices that are relatively comfortable for a person to wear for long terms and use that information. But we still have to prove that gives us information to predict which patients will get sick far enough in advance that we can change the outcome. So it's still, it's kind of an open idea. So I'm in favor of it, but we first need to prove that it actually does anything of value.
Hi, I had a question, actually a comment and question about an impediment that I see for big data is misuse, or the perception of misuse. For everyone who's had their credit card stolen at Target, or for people who are worried about data security, I think that's where some of the political motivations are coming. The airline industry dealt with this with a partnership between companies that build planes, the FAA, the NTSB, in a somewhat contentious environment. How are we going to do this in big data in medicine? FDA is not really set up as a real-time organization. Is this a federal mandate, or is this something that's going to come at a state medical board level? How do we ensure security in order to prevent misuse?
Well, misuse of data is not unique to big data. That's a real issue. And our federalist system, where the states have certain responsibilities and the feds have certain responsibilities, kind of complicate all this. It's a little easier in like some of the European countries, which are kind of more monolithic in their governmental approach. The FDA is, frankly, at sea on how to deal with all this. They haven't decided how they're going to deal with these medical analytic tools. So all those are real problems that, again, fall into what I call the challenges in the socio and political environment. I've been somewhat involved in that arena. And it is real. I don't have a good answer for it. It is a real challenge. So the technology is one thing. The ability to implement and cut across these social political challenges is in my mind the most difficult one.
I'm going to take the opportunity to ask the final question. I'm wondering if you just talk a little bit about your vision for future training of physicians as these tools start to come online, and especially now you've got really good abilities to do personalized medicine with smart decision-making aids. So how will that change, if anything, how physicians are trained?
Well, how it will change, I'm not sure. How do I think it should change? It's a little easier for me to talk about. I think some of the colleagues I work with, there's not going to be kind of a range of different physicians. There will be a group of physicians that are sort of the journeyman, kind of doing basic things. But I think more it's going to be, just as when I was in medical school, you had a basic course in biostatistics, okay? Because that was the be-all and end-all of analysis back then. I think more and more of the curriculum are going to be informatics. Okay? And as with other things, there'll be a range of people. There will be, like, there are there are 8 or 10 MD, PhD programs in informatics around the country now. So I think most every physician is going to be involved with informatics and analytics to a point. How much they're involved in this depends on what their career goals are and what the opportunities are. But I think it's that fundamental change in medical education, that critical thinking, that use of information is going to have to be part of the curriculum. It isn't there yet. There are lots of schools that still don't have that. But I think one of the things, this creation of this new medical subspecialty in clinical informatics, I think is a step in recognizing that's going to have to be the case.
All right, thank you. Please join me in thanking our speaker.